might not work for you. His technique, right? They're all different. I tend to come along. If I was to say what I do in the UK, I have one glove, right? One glove. I get the scope. I have the scope off to one side. I then PR the patient gently, right? Hand on the hip. I then scope well lubricated, and then I pass the scope in slowly. Slowly. Once it's in, start the procedure.
Right.
Okay? Some people, they'll come along, they'll have the scope here on the shoulder, they'll do this, and then they'll take the scope, and then they'll do this. Doesn't mean it's wrong. It works for them. Some people will get the scope, they'll put the finger in front, and as they take the finger out, they'll drop the scope in. Doesn't mean it's wrong. What is wrong is those ones who come along and they get the scope and then they push it in from the side like this.
That's wrong.
That's wrong. Because how would you like a scope pushed in like this? The shape of your anus is oval. The finger, and it's in this shape, and it goes oval in that shape here. If I was to be pedantic, right, what you're shown when you do your PR, you'll come along, you'll do your PR where you'll tap, then you'll draw back, and then you'll introduce your finger. Then you'll rotate. Yeah?
Yes.
I tend not to. I tend to put a little bit of gel on. My finger, like your finger, is oval.
Yes.
So I tend to put my hand facing the ceiling. I then say, just going to pass the finger just gently. So then it goes in oval to oval. Then I rotate. Doesn't mean it's right, but that's what suits me. I find it causes lots of less discomfort. But the most important thing is you're taught as a medical student to gel, put your finger forward, draw back, introduce, then rotate. I introduce this way, then rotate.
Yes.
Right? So in answer to your question, there is no answer. It's whatever you're comfortable with, but makes them comfortable.
Yes.
If you're ever going to examine a lady, I insist on a lady here. There has to be a lady down here. Always. UK, here, anywhere. I always like a lady in the vicinity. Will not do anything with a lady unless there's a lady there. Okay? All yours. What about you, Vaka? What about you?
Yeah, same.
Same.
I always put the scope straight,
The other
like you
thing,
do, and then do the rectal examinations, advance the scope straight, and then I like the scope to be straight because that's very important. So from very beginning, the scope is straight. I know.
the force transmission is.
You don't otherwise.
It'll come on, don't worry.
The other important thing to remember, especially in a lady who is obese or high BMI, always be very cautious, especially because I've seen people intubate the vagina instead of.
We've just had an incident, it's gone national,
Yeah.
where they've taken a rectal biopsy and it's the uterus.
Yes, I know.
So,
So it's always important. People report stricture in the lower rectum, which is.
I wasn't present. I'm just the one who's investigating it.
But especially if they are obese, it is very easily missed. So make sure that
And
you
I-
double.
and
also
further-
have another, another lady with you.
Yeah, you should never do colonoscopies in a lady without having a lady present. You
So
should
a
never.
chaperone should
This
be
is
there.
an absolute never. You cannot, you must not.
Yeah.
And the second thing Vakar is making a point is even more important here because we don't completely expose it. Our patients are covered and we are trying to keep it, the damn thing through the.
That's what we've touched on that, and the distance between.
And everything else because of the system. So what he's making is a very important point and without naming anybody in the last course, was with you that one of the candidates did this without realizing and then was actually not even understanding or recognizing that this is wrong. Okay, so I think this is a very important point. Another point that I want to make is that if you notice your screen, most of you, I don't know, I'm not saying most, sorry. Some centers only have one screen. And what happens is that this screen and this thing is brought here, and the umbilical, this whole thing goes across the patient. I don't know if it happens in your centers or not, but I know this happens. And then you're trying to do colonoscopy that way. A lot of things that you've learned today may not be applicable if you do that, because you've lost a lot of your movement and you're making your colonoscopy difficult. So it's only a little monitor that you need, which costs nothing. Okay, and you have a monitor in front always, and it is comfortable. It's good for your neck, everything. If you have a monitor right in front of you at the level that you are comfortable. I strongly discourage putting the whole unit here and then passing the scope so that your screen is in front of you. Okay. And as starters, you must look after your back and your neck. If you end up doing 72,000 procedures, looking at that screen and trying to push the scope forward, I can tell you, you'll not be able to, you'll probably be just looking that way now. So back is very important. I did not look after my back, I've suffered. That time, we didn't realize. But today I think these things are much more appreciated, realized.
So what's the first fold in the rectum called?
First fold in the rectum.
Anybody? Second fold? Valve of Houston. Third fold? Valve of Houston. Great stuff. Important? They're all going to go away and look it up. From a surgical point of view, it's very important, in particular the function of it and how it can give you the feelings of tenesmus and issues, and it causes a little bit of delay in the motion, and it can actually allow things to sit there. So, how are you feeling? Stop. How are you feeling?
A little resistance.
You feel a little resistance. Okay. Just look at your left. No, stop. What did we get you to do when you stop? Just stop the way you are. Look at how you got your wrist. Look at how you got your hand. Just let your hand drop down. How does that feel now here?
Uncomfortable.
Uncomfortable. Now I'm going to get you to do this. How does that feel now?
Is it better than before or not? That's all you're asking.
No,
If it's not, just tell him. Now it's easier.
Yes.
The pressure is less.
So what you're doing,
More relaxed.
as you're scoping, you're doing this. Okay? And it's a bit like if I was to give you this. Hold on to it. Pull it close. Give it me. Don't give it me. Keep hold of it. Hold on to it. See? That's how you're scoping. And when you're scoping, it's mine, it's mine, it's mine. How does that look? How does that feel? Tight. What did we talk about tension when you grip the scope? Did you remember when you gripped the scope, how it felt in the hand? How the scope felt when it went from finger to grip? And that's what happens. You're transmitting it into the scope. As soon as you start to feel resistance, think about, am I comfortable? If you're comfortable, who else is comfortable? Okay.
Yes.
Don't expinate the wrist. Watch. Whoa!
You've actually gone past the 3 times.
12 o'clock's the first presentation. So what do you want us to do?
12 o'clock is first presentation from.
It's Niz. He's just going to talk about, don't do this, but this is what you guys are all desperate to do. It was on Friday, but I've asked him because of the Friday thing.
It's been changed.
Yeah, because of what's happening Friday.
No,
Right, don't waft.
No.
So,
Good. Good.
just take a 5-minute break
Yeah.
now. Once you're done with this, they can have tea,
Yeah.
and then we can keep discussing. There's no reason for us to, we can sit down. We've been standing for a long time. And then we can come back after.
Anybody got
We're
any
all gonna be
questions?
there.
So it doesn't matter if we don't all do this time. we'll actually be
We'll
scoping
come back
shortly,
and
so it's
restart.
not a problem. Anybody got any questions? Come on, lads and ladies, you're very quiet.
How many of you report
Stop.
your colonoscopy reports in centimeters? I've reached 110
Now.
centimeters or
Look at where you are
70
there.
centimeters or 60 centimeters.
Just
Have
pause
seen
where
the
you are.
report?
Can you
Red sheet
remember
that?
where
We've seen that, especially the
she got
physicians.
and the chap before where he got?
50s and
They were all at 45. If you look at where the scope is, see how it's going. So let's look there. Now you can see where the tip is.
How certain can you be you've been to the doctor's school? How
And that
many
just
times are
opens
you
up
going
the
to be
bowel.
right? You've
See,
been to
open up the
you
bowel.
pass a certain level within the
Yeah.
right colon, transverse colon or left colon,
Excellent.
splenic flexure.
See it?
How
Now
often
drop
will
down.
you be right? Any idea?
And then you can actually then put it onto the back, and then the scope will
A
go forward.
significant percentage of time, even the best would be wrong.
Excellent. What do you think?
You just saw a demonstration, thought you just witnessed it might, whereas you were in the...
So if we now look at the scope, see how little it is, and it's in the same position.
Reporting must
And
be
you had up to there, now you've had up to
either
there.
you've completed
Yeah.
CECO,
Yes.
okay, or
Just
you've
take it
not
out, my friend.
I'm very respectful for that.
Okay, or you just simply say that, look, I have not completed the procedure.
Good.
Possibly reached transverse colon, so that when the patient goes to fall, he knows that the procedure is not being completed, or whoever. Or next time when the patient comes to you with the report, you say, well, I need to retrieve this colon because I did not see the cecum. When you see the cecum, you look at
Thank
the
you.
appendicular orifice and the ileocecal graft. We, in our
Great.
practice,
Thank you very much.
I try and get
Paul.
into the terminal ileum every time, whether it's required or not. Okay, because when you don't practice that, when you need that, you will not be able to do it. Okay? So I think it's very important to not mention centimeters and mention with some uncertainty where you are. Unless you are in CECO or you are in the rectum, where I think rectum is one of the points Paul was making, that's what brought this up, is that it's important for the surgeon to know how far you are from the anorectal junction in case there is a tumor or they need to operate. Whether they're going to do AP resection or anterior resection would depend on how far the tumor is from the anorectal junction. And that's a very important information that they would need, and that's the only time where centimeters are important. You need to write how far the lesion is from the anorectal junction.
Also anterior, posterior, how much is coated. Also when you actually PR, if you can actually feel it, how does it feel? So a surgeon wants to know how far it's in so they can actually consider about the resection that they're doing. So a thing about when you're actually positioning it in the rectum, there's an awful lot of information, but what you don't do is tattoo a rectal lesion.
T is here. It's everybody. There is no T.
Are they?